So respiratory distress syndrome is going to be a very, very big reason as to why many infants are going to show up in the NICU. And this is mainly a condition that is going to affect the preterms. So we have been covering different conditions in the NICU, starting from preterm labor, the different modalities we use for treatment, how we diagnose various conditions. And today we are doing yet another very important respiratory condition, and that is the respiratory distress syndrome. My name is Benjamin and this is Med One Pager. If you have not subscribed to the channel or if you're new, then you're very welcome. I hope you stick around to the end of this video because I'm going to be showing you very, very important things that you have to understand as a doctor. And at the end of this video, I'm going to cover the key things that I examined in the examinations. So when we look at the definition of respiratory distress syndrome, this is going to be an acute respiratory failure in neonates due to pulmonary surfactant deficiency. And we are going to see what surfactant really is. Why is surfactant very important? Because its absence is something that is going to lead to alveolar collapse, which means the alveoli, these are the functional units of the lungs, the smallest place where gaseous exchange takes place in the lungs, is going to collapse. And once that collapses, compliance or the ability of the lungs to expand and contract is going to reduce, and then we shall have less and less gases being exchanged. It is also called hyaline membrane disease. That was the former name, but now respiratory distress syndrome is more recognized. So the incidence, it is going to occur mostly in neonates who are less than 28 weeks old. That's going to be about 60 to 80%. And in a few moments, I'm going to show you exactly why this happens and some of the things that we do to see that we prevent this from occurring. So between 28 to 32 weeks, the occurrence of respiratory distress syndrome is going to be about 15 to 30%. So you'll see that for infants who are older than 28 weeks, the percentage really drops. And in the term infants, it is rare unless there are risk factors. And we are going to talk about the specific risk factor. That is going to be diabetes mellitus. So babies who are born to mothers with diabetes mellitus are most of the time going to find themselves having respiratory distress syndrome. So it is a major cause of neonatal morbidity and mortality, especially in the preterm children. These are going to die especially from this. And basically, the mortality is going on dropping because of the synthetic surfactant that is coming up, but really untreated, this has a very worse prognosis or a very bad prognosis. So we have the fetal lung development, and I'm going to just hint a little bit about it. If you're not someone who is friendly with embryology, you don't have to worry. We're not going to go through everything. We're going to see what is really important for you to know. So embryonically, from day 3 to day 7, we just have a lung bud, and this is the organ from which the lungs develop. Then they develop into the pseudoglandular phase. That is from week 7 to week 17, where there is no gas exchange that can occur in these lungs. But we just have something that is pseudoglandular, something that is not a true gland. Then we enter the canalicular phase. Now, in the canalicular phase, the lungs start to be vascularized. We start having blood vessels developing. And then this is between 17 to 26 weeks. So you're seeing in all these areas, in all these ages above 26 weeks, the baby will not be able to use these lungs no matter what. Then we have the circular phase. That is between week 26 to week 36, where we have these primitive alveoli. The primitive alveoli are going to be a bit able to produce some surfactant. They may be able to do something, but still it's not very good. And over that course of the week, when we reach about 36 weeks, most of the time we have mature alveoli, and the mature alveoli are going to have what we call the type 2 pneumocytes. Now, these type 2 pneumocytes are the ones that are capable of producing surfactant, and therefore, starting from weeks 24 to 28, we are able to produce surfactant, but adequate surfactant is going to be produced after 34 weeks. And when you look at some of the guidelines in OBGY, in obstetrics and gynecology, mothers are given these antenatal steroids before 34 weeks. And this is because we want to speed up the lung maturity. And we assume that by 36 weeks, these mothers the baby has mature alveoli, unless you have reason to find why you would suspect they are not. So the surfactant physiology, the composition, it is made up of this compound, and that is DPPC. I'm not going to try to pronounce it, but yeah, and there are proteins also, and these are the proteins that are found in the surfactant. So the function of these proteins is that they're going to reduce the surface tension via what we call Laplace's law. Now, I'm not going to go through Laplace's law, but basically it just talks about the radius of an object and the amount of pressure that it needs. So basically what is here is that alveoli easily collapse. And for them not to collapse, there has to be something that breaks the surface tension. That is what is being talked about. The surfactant also prevents alveolar collapse. That is what we call atelectasis. It improves the lung compliance and reduces the work of breathing. So when we look at the pathophysiology of what happens in respiratory distress syndrome is that we are going to first of all lack surfactant. When we lack surfactant, surface tension is going to rise. When surface tension rises, the alveoli are going to collapse. And this is going to reduce the functional residual capacity within the lungs, because if part of the lungs are collapsing, the functional units are collapsing, then the functional residual volume is going to definitely go down. And then we shall have a ventilation perfusion mismatch. This is going to lead to carbon dioxide levels going high, which is hypercapnia, and this is going to lead to a respiratory acidosis. Now we shall have endothelial damage, and when we have endothelial damage, we shall have protein-rich exudates. This is within the lungs. Endothelial damage is taking place. We have protein-rich exudates, and those protein-rich exudates are the ones we are going to find as hyaline membranes. That's why the disease used to be called hyaline membrane disease. Now, when we have a decreased lung compliance, we're going to have an increased work of breathing because the part of the lungs are compromised. We have to compensate. The work is going to increase, and that can cause fatigue, especially in a neonate who is weak, and this is going to lead to respiratory failure. So when we look at the risk factors for respiratory distress syndrome, diabetes mellitus is going to be very, very important in the mother. If a mother has diabetes mellitus, they're going to have a hyperinsulin state. And insulin, when it is in high levels in the body, is going to decrease the rate of surfactant synthesis. Elective cesarean section, where there has been no labor, may also contribute to this problem because of a decreased catecholamine surge. Remember in the previous video we covered a very important topic, which is transient tachypnea of the newborn. If you have not seen it, then go back and see it. You'll see what we talk about, where we talked about this catecholamine surge and the elective C-section. So we have perinatal asphyxia. If the baby had asphyxia if there was some form of asphyxia, then we have a high risk. So when we look at the fetal risk factors, prematurity is an important risk factor. Male sex is an important risk factor. Multiple gestation, having very many twins or very many babies at once. They could be twins, they could be triplets, and so forth. Most of the time, these babies are born before the gestation age or before they are actually mature, because the womb simply has not enough room for two babies most of the time. The genetic surfactant protein deficiency can also be a thing that causes this. Now, the protective factors, one of them can be antenatal steroids. When we give steroids prior to babies about below 36 weeks, they can help speed up the growth of the lungs, and then we have lung maturity. Now, chronic intrauterine stress is another important factor, and we shall look at different concepts, things like twins, where we have twin-to-twin transfusion, or in conditions where babies have been having this chronic uteroplacental insufficiency. These babies have a high level of cortisol, which causes the lungs to mature very fast. The intrauterine stress causes them to actually have their lungs maturing faster than the babies who have not. So the clinical features we can see, the onset, it's going to be immediate after the baby is born or within 6 hours after birth. And then the signs that we normally see, we see tachypnea, and then we see grunting. And grunting is a very important indicator because it is a positive expiratory pressure generator. So the baby is trying to simulate what it would be like when they're having CPAP on. They're trying to breathe against a closed upper airway. They're closing their upper airway and trying to breathe against that, so that as they breathe out, the pressure is kept inside within the lungs, and that is going to help keep the alveoli open. So if you just go ahead and give this baby some CPAP, that is the continuous positive airway pressure, and I covered this in the video. If you have not watched the video on CPAP, please do cover the video. Make sure you understand how CPAP works. So this baby is trying to give themselves CPAP as they wait for you to come in and help them breathe better. Nasal flaring is going to be a common thing that you're going to see in all children who have respiratory compromise. Intercostal or subcostal recessions, these are basically the extra muscles for respiration. They're using the extra muscles to try and respire. Cyanosis is going to be something that will be apparent because of the poor gaseous exchange, and when it's severe, they're going to undergo apnea or exertion, where they will completely stop breathing and then maybe pass on if you do not come in to intervene. So we have the severity assessment, we have the Silverman-Anderson score. You are going to go and look at it. I did not include it in this video, but it's something that has 5 parameters, and it's basically gauging the rate of respiratory distress. Then we have to do the arterial blood gases, where you see the partial pressures of oxygen will be low, the partial pressures of carbon dioxide will be high, and the pH is going to be low because of a respiratory acidosis. The diagnosis is going to be clinical plus the risk factors. A neonate is born before 34 weeks. What do you expect? This is going to be respiratory distress syndrome 1-on-1. And then when you look at the chest x-ray, sometimes you see the ground glass appearance. Sometimes you may see the air bronchograms, which is air trapped within the lungs, and then low lung volumes. When you do the labs, the arterial blood gases are going to have the abnormalities we saw above, the high carbon dioxide, low oxygen, low pH. And prenatally, sometimes we can predict, we can try and see, is this fetus having mature lungs or not? And some of the tests we do, these are very, very high yield for you to remember. We have the length-thin sphingomyelin ratio. And if that ratio is less than 2, then we have a high risk that these lungs of this fetus are not yet mature. We have the lamellar body count, and we have the form stability index, or what we call the shake or the bubble test, where we are going to pick some amniotic fluid and put it into some alcohol and shake. And if we have formation of a stable form, then you know the status of the lungs. I will make a video on this particular topic that will be long enough. So if you haven't subscribed to the channel, make sure you subscribe so that you don't miss out on that video. The ultrasound can also be used to predict whether the fetal lungs are mature, and things like the pulmonary artery Doppler are going to be very important, because as the lungs go on to mature, the vascularization is going to change, and you can see that on the pulmonary artery Doppler. Then lung to liver echogenicity. This what is going to be liver. So the liver is looked at with an ultrasound as well as the lungs, and then we look at the difference in the echogenicity, and that can tell us if the lungs are mature or not. Epiphysio ossification centers can help us just tell if the age of this baby. You look at the femur, you look at the long bones, see if there is some ossification taking place, and that can help you determine the age of this infant, which can in fact help you determine if they are at a high risk of developing that. We look at the differentials. These are going to be all the respiratory conditions that affect the newborn: the transient tachypnea of the newborn, meconium aspiration syndrome, which is the next video I'm going to do right now, neonatal pneumonia or sepsis, pneumothorax, and congenital heart disease. So I want us to look at the management. How do we manage kids who have respiratory distress syndrome? One, we have the prevention, and that is the antenatal corticosteroids. We can use the betamethasone, which is given between 24 to 34 weeks, or we can give dexamethasone. And then we avoid elective preterm delivery wherever possible. B, we can go to the delivery room care, where you have to make sure you keep them warm, because we saw that preterms have issues with temperature regulation, airway positioning, and then early CPAP is preferred over intubation. CPAP is very important, because before these alveoli collapse, prevent them from collapsing in the first place. That is what CPAP is going to do. And I'll urge you, if you have not watched the video about CPAP, please go and watch it, because it's going to clear a lot of noise for you when it comes to oxygen management in children. Then we have respiratory support. CPAP again is the first line. Oxygen therapy, you want to target an SpO2 of about 90 to 95%. Mechanical ventilation if there is severe distress, apnea, or carbon dioxide retention. Then surfactant therapy is very, very important. We have different types of surfactant. We have the Ensure protocol, we have the Lisa protocol, and you have to understand this in very, very, very good detail. Maybe we shall make a very detailed video about surfactant therapy. So we have the early exogenous surfactant. This is where you're going to intubate this infant, give them the surfactant, and then immediately extubate them and keep them on CPAP. It reduces mortality as well as the complications that are related to ventilation or using a ventilator for a prolonged period of time in neonates. Supportive care is very important, where we can give the fluids, the nutrition, thermoregulation, and treat sepsis if it is suspected. So we are nearing the end of this video, and now we're going to look at the prognosis. And this is important because with the endogenous surfactant, if we give the surfactant, then we can have improvement within 3 to 5 days. With the extreme prematurity, things are going to worsen. If there are no antenatal steroids, it's going to be worse. If there's delayed treatment, mortality is going to increase. But in the modern NICU care, nowadays, we are having less and less of this. So the key examples that you always have to remember is that the most common cause of respiratory distress syndrome is being preterm. And what you're going to see on your x-ray is the ground glass appearance with air bronchograms. This is very, very, very high yield, and you have to remember it. You have to give antenatal steroids and early CPAP, as this will reduce on the course of a disease. Surfactant deficiency is the core pathology, and Ensure technique is very, very high yield. Get the infant, intubate them, provide them with surfactant, and then extubate them. My name is Benjamin. This has been Respiratory Distress Syndrome, and this has been Med 1 Pager. Let's meet in the next video, which is going to be about meconium aspiration syndrome.